Achilles Tendinopathy, power and pettiness. Welcome to the evidence-based street rehab, where we cut the crap on Achilles tendinitis. Yeah, I said it. If you still call it tendinitis, cool. That's vintage, except that here we are not fucking hipster physios drinking kombucha and listening to indie rock shit. So in science, no vintage shit, please. This isn't some simple inflammation, it's a degenerative tendinopathy saga. Time to get real with a clinician style. Tendons aren't overreact overnight like your ex, they live on a continuum. Back in 2009, Cook and Purdam schooled us. An Achilles can go from reactive, acute overload, to degenerative, chronically jacked up if you mismanage it. And guess what? Load is the puppet master here, but real load. Push that tendon forward or back along the continuum. Manage the load right, and a reactive tendon can revert to normal with progressive management in 6 to 8 weeks. Don't expect a shortcut tendinopathy cheat code, otherwise you'll start all over. Screw it up, and you're left with crispy collagen and a patient cursing your name. The Dutch, Lekker, multidisciplinary crew backs this up too. They lay out everything from risk factors to imaging. So, pro tip, they only recommend imaging if you smell something fishy or the diagnosis is in doubt. So don't MRI every Tom, Dick and Harry with heel pain. In short, know the stage, respect the load, or the Achilles will make you pay. Achilles tendinopathy hits like a turf war on your calf. Pain, oh yeah, often dull at first, then raging after you push it. Morning stiffness, count on it. That classic hobble out of bed is practically diagnostic. The tendon's been sulking overnight and reminds you with every first step. Power loss? Absolutely. Your Gastrocs Soleus unit becomes a shadow of its former self. Patients feel weak push-off, less jump in their step. Literally, muscle power deficits are part of the official diagnosis label. It's Achilles pain, stiffness, and muscle power deficits for a reason. Pain Science 101. Chronic pain here isn't just from tissue damage, it's also your tendon acting like a bratty alarm system. Sensitive, stiff, and refusing to do its job at full power. Our job? Calm the alarm and rebuild that power. Train both sides hard as fuck and then pause, but don't coast. Never sleep on old results. Tendon rehab isn't a Netflix binge, it's an active grind. Progress from isometrics, pain modulation, to isotonics, isokinetics, strength foundation, to plyometrics, explosive control. Keep the chain moving and forget the eccentric-only gospel. That bullshit has been retired. A key 2015 RCT by Beyer et al. Showed heavy slow resistance, HSR, which includes both concentric and eccentric loading, was equally effective as Alfredson-style eccentric-only training in reducing pain and improving function for mid-portion Achilles tendinopathy. All right, enough whining. What's the plan? Load the tendon. The 2024 JOSPT Guidelines drop the hammer. Exercise is first line and not cutesy, TheraBand foo-foo. We're talking tendon loading as heavy as tolerated. Level A evidence. Give your patients the green light to push it, yes, some pain is okay, to improve function and smash pain. In fact, have them train at least twice a week at high intensity. If it's not a 7 out of 10 effort, it's probably a 0 out of 10 intervention. Eccentrics, concentrics, isometrics, isotonic, plyometrics. It's all fair game in a progressive program. Whether you're Team Alfredson, heavy eccentrics, or Team heavy slow resistance, both get the job done. Isometric holds, they're the unsung heroes for pain modulation. A 45-second heavy hold can mute pain like a charm when things are too spicy to move. Bottom line, exercise therapy has the highest evidence for Achilles rehab. Passive crap alone won't cut it. 3 separate systematic reviews confirm loading beats a wait-and-see approach. Patients improved about 20 points more on the Visa A score with exercise versus just waiting around. Translation, wait and see equals wait and stay hurting. Get them moving, under load, and watch improvements follow. Now let's talk muscle behind the tendon, the dynamic duo, Gastrocs and Soleus. If you rehab Achilles without hitting both, that's like bringing a knife to a gunfight. Gastrocnemius, the showy upper calf muscle crossing the knee packs, fast twitch fibers for days, great for that sprint or jump. Soleus, the deeper workhorse, is almost 100% slow twitch, built for endurance and posture. Fun fact, Soleus is a beast, the largest lower leg muscle, capable of generating up to 8 times body weight force during running. Meanwhile, Gastrocs manages around 3 times vertical force. No wonder the world's fastest marathoners sport tree trunk Soleus muscles, and a weak Soleus pretty much predisposes you to Achilles problems. Research confirms it. Runners with Achilles tendinopathy showed big strength deficits primarily in the soleus and not just on the injured side. The good side was weaker than healthy controls too. In other words, that lazy soleus was a ticking time bomb before pain even hit. So quit making rehab all about glamorous straight knee calf raises. Bend the knee, load the soleus, seat your patient on a leg press or throw on a heavy backpack for bent knee heel drops. The deep fibers of Achilles, where soleus attaches, will thank you. That's exactly where most mid-portion tendinopathy damage shows up. Train the soleus like the unsung hero it is, or you'll rehab one problem just to see it bite back later. Now, time to put 3 big rehab myths on notice. Myth number 1, just rest it out. Sure, a brief deload can calm a screaming tendon, and acute reactive tendinopathy might need you to pump the brakes a bit, but complete rest as a treatment? That's like telling a broken engine to fix itself by not running. Good luck. Tendons hate long vacations. Even 2 to 3 weeks of bed rest makes them weaker and more stretchy in a bad way. The Dutch Guideline reminds us Achilles tendinopathy is an overuse issue. Modify activity, don't just halt it. And those JOSPT experts found that doing nothing, wait and see, left patients significantly worse off than those who exercised. So rest it is advice better left in the dumpster. Instead, we load to rebuild capacity. Rest equals rust. Myth number 2, stretch it and it'll be fine. We've all seen patients obsessively stretching their calves, thinking it'll magically realign their tendon fibers. Truth bomb stretching an already irritable Achilles often does diddly squat for long-term improvement. In fact, aggressive stretching, especially of the Achilles, can even worsen the condition in some cases. You're essentially yanking on damaged collagen and potentially adding compression, particularly bad for insertional Achilles issues. The latest guideline only gives stretching a lukewarm endorsement, maybe to temporarily ease pain. So, if it helps symptomatically, fine. A bit of gentle calf stretching won't kill anyone. But don't fool yourself. Stretching is accessory, not therapy. You can't yoga pose your way out of a tendinopathy. Myth number 3, NSAIDs for chronic Achilles pain. Ah yes, the old take 2 ibuprofen and call me in the morning. Hate to break it to you, but in chronic Achilles tendinopathy, inflammation isn't the headliner. We're dealing with disorganized collagen, neovascularization, maybe some nerve ingrowth, not a hot, swollen ankle sprain. Studies show loading and exercise improve symptoms, with no added benefit from NSAIDs in early tendinopathy. And long-term, NSAIDs might even hinder tendon healing by suppressing the very repair processes we need. Clinical guidelines are clear. For degenerative tendons, NSAIDs and corticosteroid shots give only fleeting relief, if any, and won't restore function. Worse, steroids can risk actual tendon rupture. So tell your patients to stop popping pills as a crutch. If they insist on an NSAID, make sure it's short-term and for a good reason, like calming a reactive flare just enough so they can do their exercises. But chronic Achilles pain, you can't medicate it, you must load it. So here's the deal, folks. Achilles tendinopathy rehab isn't a walk in the park. It's a gritty West Side rumble, and you, the clinician, are in charge of turning the chaos into a comeback. Remember, the big hits load heavy and smart per 2024 guidelines. Respect the continuum, thanks Cook and Purdam. Train both Gastrocs and Soleus, no muscle left behind. And don't fall for the rest/stretch/NSAID lullaby. Educate your athletes that pain does not equal damage, that a stiff morning Achilles is common but beatable, and that with the right loading, power will return. Now get out there and apply this. Turn Achilles' heel from a weakness into a strength. This is Physio-Logical rehab, where evidence meets patient and trumps old myths every day.